average woman, has 2 children. She spends 5 years trying to get pregnant, being pregnant, but the average woman spends 20 plus years trying not to get pregnant.
The pill, the patch, all of those things lend themselves to error, not because women are irresponsible, but because they're human.
We have a lot of patients who come into our clinic, more and more now, asking for long-acting methods such as the IUD and the Implanon.
They love the fact that they don't have to really do anything, that they don't have to remember anything, and that they have several years to decide when it is the right time for them to start their family.
To have a method that you can rely on and not think about for 5, 10 years, it's really a breakthrough for women.
The end result is that they're not having unintended pregnancies, which is what the patient wants, and it's what we want to help the patient achieve.
49% of all pregnancies in the United States are unintended, a rate higher than any other industrialized nation. One way we could decrease the rate of unintended pregnancy would be to offer more women long-acting reversible contraception, also called LARC. Only 6% of U.S. women use long-acting reversible methods. Methods that include the levonorgestrel-releasing IUD, the Mirena, the copper-releasing IUD, the Paragard, and the single-rod etinogestrel-releasing implant, Implanon. These methods can work for many years, at least 10 years for Paragard, 5 years for Mirena, and 3 years for Implanon. They are also extremely effective, with fewer than 1% of women becoming pregnant in a year of use, about as effective as sterilization. In this video, women's health providers from around the country explain how these safe, effective methods can be better integrated into your clinic practice, and explain how to make long-acting reversible contraception more accessible to your patients.
% of American contraceptors in the early 70s used intrauterine contraception. But a few years after that, bad research and bad experience with the Dalcon Shield caused the use of intrauterine contraceptives to plummet.
And there was a huge controversy over that, lots of legal battles, legal suits, and doctors just felt the IUD was a bad method when in fact it was this one particular IUD.
Since then, we've developed much better intrauterine contraceptives and done much better research to document their safety and effectiveness. And we're beginning to see an increase in the use of intrauterine contraceptives.
In the past, few women were considered good candidates. Most providers would only give IUDs to women in monogamous relationships who already had children and who had no history of STDs or pelvic inflammatory disease.
We would turn a lot of women down who didn't have children and were really interested in getting the IUD.
One of the reasons I think we limited the IUD to that narrow group of women who are married and have children, is because of sort of unsupported notions or fears that somehow the IUD may cause infertility. The reality is the IUD does not cause infertility.
It's clear from well-done epidemiologic studies that intrauterine contraceptives do not increase the risk of pelvic inflammatory disease, and they lower the risk of not only intrauterine pregnancy, but of ectopic pregnancy.
Based on a large body of research in the last 30 years, it is now clear that most women are candidates for IUDs. Nearly all women are candidates for Implanon. Although many women are LARC candidates, they face several barriers to access. LARC methods may have high upfront costs. Too few providers are trained to insert them. Many women are not aware of LARC, and those who are may find it difficult to get them. Recent research and new efforts to educate providers and the public are working to increase access to long-acting methods in this country.
I remember thinking, this is like blasphemy that we're going to start putting IUDs in teenagers. But I did do a lot of reading. And so once I got comfortable with that literature, I started to feel comfortable with putting IUDs in young women.
They don't necessarily have to be in a monogamous relationship. They don't have to be older. They don't even have to have had any children.
They can have an IUD even if they are not just with one partner. They can have an IUD immediately after an abortion.
I would tell any woman who I'm giving a birth control method, birth control pills, the patch, or the ring, is that these methods don't protect from STDs, and it's not good for you to get STDs. But with an IUD, your message shouldn't be any different. It should be that this method doesn't protect you from infections. If you get an infection with an IUD, that it's not going to be any worse than if you didn't have an IUD. So the message should be is that infections are bad, not IUDs.
It's really important to get clinicians comfortable with IUD placements, and that includes both addressing the myths around IUDs, their own biases, all of the new evidence for broadened indications, and then especially for clinicians who are new, it's great to provide some kind of proctoring.
All of your staff have to be comfortable in a clinic setting with this method because your patients interact with your front desk staff, they interact with the counselors, they interact with the nurses.
Implanon is the newest long-acting method, and training on Implanon insertion is becoming available throughout the United States. It's also important to have staff proficient with this method.
What we call long-acting methods are intended for use for 5 to 10 years, and I always stress the word intended.
But it's important to make clear to patients that they don't have to use them for that long.
When they do want to have a family, then we just take the IUD out.
Return to fertility is immediate.
Women tolerate insertion of both the Implanon and the IUD very well.
I think the most important thing to emphasize is the irregular bleeding.
After IUD insertion, women may have spotting and cramping for several weeks. With the Mirena, bleeding and cramping decrease over time, and about 1/3 of women stop having periods. With Paragard, periods may be heavier, particularly in the first 6 months. With Implanon, bleeding may become irregular or stop.
What we found is if women are provided with the proper education and information during their visit with us, then very, very few women will have these methods removed before they're ready to start a family.
There's really good evidence now that with post-abortal IUD, there is not a significant increase in infection, in perforation, in expulsion, or in discontinuation.
Research at Planned Parenthood showed that among women who were given a contraceptive method following their procedure, those who chose IUDs were 1/3 as likely to have a repeat abortion as those who chose a different method.
It's so quick after the procedure, they already have medication on board, their cervix is already dilated. It's less than a minute after the procedure to place it.
The joy of somebody's face when you tell them they can have their Implanon that day, right after their procedure, we'll just move you into another room and do your Implanon, has been so wonderful and so exciting to see.
What really is the barrier, I believe, in most provider schedules is the time. If a provider does not have the time to do the counseling, then they're less inclined to offer that service.
So it does take a little bit more time to consent the patients, and our staff has been really well trained in how to consent them so that the patients understand really well about the IUD. Then in the room, it really doesn't take very much more time. It's a few more minutes just to make sure that they're comfortable and sure, and then the IUD just takes, it's less than a minute. It's very brief, and it's so convenient that it's really worth the time that it takes.
Like the IUD, the new single rod implant takes less than a minute to insert. Many clinics have found that the most efficient way to offer long-acting methods is through same-day services.
It was conventional for women to have to come to a screening and then come back for an insertion visit. And what we have found is that 40 to 50% of women don't ever return for that second visit.
So typically a woman can come in and be a new patient, want her IUD, and we'll insert that day. We'll do the screening test as needed. we don't have to wait for those results to come back for chlamydia and gonorrhea, pap smear results, and iron level results. We rule out pregnancy, and she can get her IUD and leave that day. So if somebody's test does come back positive after they've left the clinic, we follow our regular treatment plan, whether that be antibiotic, follow-up pap smear, with really no impact on the IUD insertion itself.
Generally, the feedback that we've gotten from patients is really positive. They're extremely satisfied that they were able to get their IUD on the day that they came to clinic.
Although many patients want long-acting methods, cost can still be a significant barrier. But over time, long-acting methods are far more cost-effective than other methods. You can help patients with the upfront costs of LARC by giving them installment payment options, using the manufacturer patient assistance plans, and helping them with their insurance.
If you allow a woman to have a birth control method she can forget about for years, then you eliminate the pharmacy barrier, you eliminate the provider barrier, the annual exam barrier, and she can just have a birth control method.
We're seeing much higher continuation rates with IUDs and Implanon, 75–85% continuation rate at the end of the first year.
They're very effective methods. Less than 1 in 100 women in the first year of use are going to get pregnant with these methods.
It's safe, it's effective, and when women hear about it, they want it.
I like to know that a patient is choosing a method that really is going to put her more in the driver's seat going forward about when she's going to get pregnant again.